This lecture is part 5 of the unit on neurological conditions. It's going to cover the nursing management of the patient with a stroke. The most important thing to remember about a stroke care is time. After stroke onset, immediate medical attention is crucial to decrease disability and risk of death. I'm going to focus on the nursing management of stroke, but be sure to read the chapter to familiarize yourself with the patho and the definitions. A stroke is an interruption of the blood flow to the brain. Sounds simple, and basically it is. The terms brain attack and cerebrovascular accident, or CVA, are also commonly used in the place of the word stroke. The term brain attack communicates the urgency of the situation to the public, much like the term heart attack. A stroke can be caused from two different pathologies, either a clot, which is an ischemic stroke, or a bleed, which is a hemorrhagic stroke. In both of these situations, blood flow to the brain tissue is impaired. And what we've learned from the previous lecture about injury to the brain, well, we know it swells and it produces cerebral edema and increased ICP and finally cellular death. You can see how most of what you learned in the last lecture will be applied here. We're going to talk a lot about perfusion, decreasing cerebral edema, and preventing further neurological injury. So don't forget those interventions you learned in the last lecture. You can see from this table the differences between ischemic strokes and hemorrhagic strokes. Ischemic strokes account for approximately 80% of all strokes, with 60% of those being thrombotic strokes, meaning a blood clot has formed at the area of injury to a vessel. So this means there's an atherosclerotic plaque that has formed inside of the artery, and the resulting inflammation causes a blood clot to form there. These types of strokes can have a type of warning sign to let you know they're probably going to happen. The warning signs are called TIAs, or transient ischemic attacks. You'll also hear these called mini strokes in the community. Ischemic strokes can also be from an embolic event in which a blood clot or debris circulating in the blood gets clogged in the small arteries of the brain, where it blocks the blood flow to the distal portion of the artery. These are usually from either inside the heart, where it can be from atrial fibrillation, myocardial infarction, infective endocarditis, or other things. They can even come from an air emboli or a fat emboli from a long bone fracture. There are usually no warning signs because it's a sudden event when that clot or debris lodges in that small artery. There's usually no atherosclerotic damage to the vessel, so there's no timely buildup to manifest a TIA. Now, the absolute opposite of an ischemic stroke is a hemorrhagic stroke. These occur when there's bleeding in the brain, usually from a ruptured vessel, whether it be a ruptured aneurysm, atherosclerosis, or a congenital malformation. Remember all of the various structures inside the brain and between the brain and the skull. There can be bleeding in any of those places. Inside the ventricles, inside the brain tissue, bleeding between the brain and the skull, and in between the meninges of the skull. Hypertension is the most common cause of intracerebral hemorrhage. Other causes include vascular malformations, coagulation disorders, anticoagulant or thrombolytic medications, brain tumors, ruptured aneurysms, and trauma, like you learned about in the previous lecture. Now let's talk about a TIA. You'll also hear that TIAs are called mini strokes. These are important because they're a warning sign of a potential impending ischemic stroke. These are thought to be microembolic events temporarily blocking blood flow to the brain tissue. Then these emboli pass on and blood flow is resumed and the symptoms usually resolve. The symptoms usually last less than 1 hour. You're going to see patients who've come in for a stroke, and when you ask them if they've ever had these symptoms before, many of them will say, yes, I had some numbness a couple of weeks ago and it went away, or I couldn't move my hand 2 days ago, but it got better. TIA should be treated as a medical emergency because there's no way to tell when these patients present to us whether or not they're experiencing a TIA or an actual ischemic stroke.
A stroke, also called brain attack or cerebral vascular accident, occurs when brain cells die from oxygen deprivation. Oxygen deprivation occurs if blood flow to the brain is blocked by a clot or if vessels are damaged. Without oxygen, brain cells cannot function. There are two types of stroke, hemorrhagic and ischemic. A hemorrhagic stroke occurs when a blood vessel in the brain bursts due to high blood pressure, atherosclerosis, or a congenital malformation. A burst vessel causes bleeding into the brain and decreased blood flow in the damaged vessel. Blood buildup increases pressure in the brain, damaging nerve cells and collapsing smaller vessels. The second type of stroke is ischemic stroke, which occurs when blood flow through a vessel is blocked. There are three categories of ischemic stroke: thrombotic, thromboembolic, and embolic. A thrombotic stroke occurs when flow in a blood vessel in the brain is obstructed by arteriosclerosis. A thromboembolic stroke occurs when a clot breaks off from an arteriosclerotic plaque and lodges in a downstream vessel, blocking blood flow. An embolic stroke occurs when a clot travels to the brain from elsewhere in the body. Patients with atrial fibrillation or who have suffered a heart attack are at high risk of embolic stroke. This is because slow, irregular, or interrupted blood flow has a tendency to clot. Sometimes an individual will experience a transient ischemic attack, TIA, which is temporary and improves before cells die. A TIA is a precursor to a thrombotic stroke or short-term embolus.
Let's review the anatomy of the brain before we move on. The brain is supplied with blood via two major pairs of arteries: the internal carotid arteries, which supply the anterior circulation, and the vertebral arteries, which supply the posterior circulation. These two major routes of circulation are joined at the Circle of Willis. This structure is so important because it serves as a safety net for cerebral blood flow when differential pressure or vascular occlusions are present. This means if there is an occlusion, for example, in the anterior cerebral artery, the brain will still be able to receive oxygenated blood through other arteries such as the internal carotid or the middle cerebral. This collateral circulation is an important concept because this is what saves some lives when a stroke occurs, whereas other people who may not have had extensive collateral circulation may show very different symptoms from the same location of occlusion. Don't forget the concept of autoregulation that we covered in the previous lecture. This concept is how the brain protects itself from changes in mean systemic arterial blood pressure between 50 to 115 millimeters of mercury. Now let's consider factors that affect cerebral blood flow. Remember, the blood vessels vasodilate or vasoconstrict in response to changes in pressure. Also, carbon dioxide is a potent vasodilator. Increased CO2 levels increase cerebral blood flow, whereas decreased CO2 levels decrease cerebral blood flow. Very low arterial oxygen levels, such as a PaO2 of less than 50, also increase cerebral blood flow. Again, this is all part of autoregulation. The body can detect when the oxygen supply to the brain tissue is low, so it increases blood flow to try to increase oxygenation. MAP autoregulation can only occur when the MAP is above 50 or less than 150 millimeters of mercury. With no cardiac output, of course, there's no cerebral blood flow or systemic blood flow for that matter. Cardiac output must be reduced by 1/3 to reduce cerebral blood flow. What does that tell us? This means that the body is going to perfuse the brain tissue before it perfuses other organs. Also, what about blood viscosity? It decreases as blood flow increases. Collateral circulation develops over time to compensate for a decrease in cerebral blood flow. This is important with thrombotic strokes because as the plaque builds up and blood flow is decreased, hopefully collateral circulation will form, which will help reroute the blood in case of an actual ischemic stroke. What about ICP? We know that the brain is compressed and cerebral edema forms, causing decreased CBF. One of your major goals when caring for a stroke patient is to reduce the secondary injury related to ICP. So don't forget the nursing interventions we've already covered that aim at reducing ICP. Let me introduce a major concept here for stroke management. Elevated blood pressure is common immediately after a stroke, and this is thought to be the body's attempt to maintain CPP. The body detects that part of the brain isn't getting enough blood, so it raises the blood pressure in order to raise the CPP. You can see how this could help or be detrimental in a stroke patient depending on what type of stroke it is. So what is the nurse's role in stroke care? Well, we have several. Prevention is one of them. The most effective way to decrease the burden of stroke is to prevent it altogether. We need to educate the community and our patients about the risk factors for stroke. Survival. This is also important. The actions taken during the acute phase of a stroke has a major role in the outcome for the patient. The public needs to be educated on the signs and symptoms of a stroke and what to do when it occurs. The reason fast intervention is so important is because the brain needs constant blood supply to provide the glucose and oxygen needed to function. The brain tissue begins to die within 5 minutes of lack of blood flow. We're also going to talk about limiting complications and recovery, as well as minimizing disability and maintaining an optimal quality of life for these patients. Risk factors for stroke are divided into non-modifiable and modifiable risk factors. The non-modifiable are listed here. These are things the patient can't do anything about. Why are these so important? So we can identify those patients at risk for stroke based on non-modifiable and modifiable and teach them control the modifiable risk factors. Stroke does increase with age, but stroke can occur at any age. It's more common in men, but more women die from strokes. African Americans also have a higher incidence and a higher death rate. If you have a family history of stroke, your risk also increases. Now let's discuss the modifiable risk factors for stroke. These are important because these are the things the patient can change. Hypertension. Yes, you can modify hypertension. This one is huge. This is the single most important modifiable risk factor, but it is widely undetected and inadequately treated. Stroke risk can be reduced by 50% with the appropriate hypertension treatment. Hypertension accelerates atherosclerosis, which can lead to the thrombotic stroke due to the damage from blood vessels. And it's also the most common cause of intracerebral hemorrhage from the pressure it exerts on the microvasculature. What about heart disease? Well, atrial fibrillation is complicit in about 20% of all strokes. This happens when there is stasis of blood in the atria where clots form. Also, cardiomyopathy is an issue, cardiac valve abnormalities, and even congenital defects. Then there's diabetes mellitus. People with this are 5 times higher than the general population to be at risk for stroke. And then there's smoking. This actually doubles the risk of stroke. However, if a smoker will stop, then your risk does substantially decrease over time. Then there's alcohol. Alcohol consumption leads to hypertension, which increases stroke chance. And then there's illicit drugs such as cocaine or other stimulants. And obesity increases stroke risk in all ethnic groups. This contributes to hypertension, high blood glucose, and elevated cholesterol. So, what does this matter? You can see how you need to combine the non-modifiable and the modifiable risk factors to see if your patient is at risk for stroke. If so, teach them ways to reduce the risk from the modifiable risk factors. Teach, teach, teach. Preventive therapy for stroke is very important because we can identify those people using their risk factors before a stroke occurs. The nurse plays a key role in health promotion. This helps to decrease stroke risk for both ischemic and hemorrhagic strokes. We want to focus on a healthy diet, weight control, regular exercise, smoking cessation, limiting alcohol consumption, and routine health assessments to identify those modifiable risk factors such as diabetes mellitus, hypertension, and hyperlipidemia. There are several approaches to preventive drug therapy also, mostly for those patients at risk for ischemic strokes. Antiplatelet drugs are usually the chosen treatment for those patients who have experienced a TIA. Usually they're placed on aspirin, ranging from 81 milligrams up to 325 milligrams per day. There's also a new drug on the market called Vorapixar, Vorapaxar, and this is the generic name. That is a new antiplatelet. Patients who have atrial fibrillation should be on anticoagulation medications to reduce the risk of stroke. Also, statin drugs have been proven to reduce the risk of stroke for those patients who've had a TIA. For patients who've had TIAs due to carotid disease, there are various surgical interventions that can be performed to reduce the risk of stroke from carotid plaque. The clinical manifestations of a stroke depend on the location of the injury. These are some general clinical manifestations of strokes, whether they be hemorrhagic or ischemic. Notice that the most obvious effect from the stroke is on motor function. The patients have problems with mobility. The patient will have a motor function involvement contralateral to the side of the stroke, meaning the deficits will be on the opposite side of the stroke affected on the brain. This is because of the pyramidal pathway that crosses at the level of the medulla. The patient may have difficulty with communication, and we'll discuss these terms later. Memory and judgment can also be impaired. Left brain strokes are more likely to result in memory problems related to language. They're often cautious in making judgments, whereas the right brain stroke patient tends to be impulsive and move quickly. Patients with either type of stroke may have difficulty making generalizations, which interferes with the ability to learn. We'll discuss the other clinical manifestations listed here in just a moment. There are many resources available for patients and nurses to help educate the public. The American Stroke Association teaches the acronym FAST to help educate the public. F stands for face. Is there facial drooping or numbness? A stands for arm weakness or numbness on one side. Does one arm drift downward? And S stands for speech difficulty. Is speech slurred? Is speaking difficult or hard to understand? And T stands for time to call 911 if any of these symptoms are present, even if they go away like a TIA. Call 911 and notice the time when symptoms first appear. The term brain attack is used to convey the sense of emergency. In your book, there is a table that teaches the warning signs of a stroke. So who are you going to teach these signs to? The patients that you have determined are at high risk for stroke based on their non-modifiable and modifiable risk factors. So now let's talk about why acting fast is so important and why time has been emphasized so much. Now you know that a stroke can be hemorrhagic or ischemic. And even though we haven't discussed it yet, you can imagine that treatment will be different for an ischemic versus a hemorrhagic stroke. So it's very important for the treatment team to determine if the stroke is ischemic or hemorrhagic. And the way we do this is through a CT scan. The goal for the stroke center is to get the patient in the CT scanner within 25 minutes of arrival. This isn't a lot of time to identify the stroke patient, secure the ABCs, and get the patient to the scanner. So you can also see how important pre-hospital treatment by the EMS is, and communication to the hospital to get ready for the patient. Remember, brain tissue begins dying 5 minutes after the stop of blood flow. The patient will also undergo MRI imaging, which will help identify the size and location of the stroke. But MRIs take a lot longer than a CT, so that's why a CT is performed first. Also remember that heart disease is a modifiable risk factor for stroke, so the patient will most likely undergo cardiac studies, especially if the stroke is ischemic. Now let's look at the nursing process for the patient with a stroke. The important thing for you to remember is that the clinical manifestations are related to the location of the stroke. For the purpose of this lecture, we're going to discuss the general manifestations and treatments of both ischemic and hemorrhagic strokes together, with specific aspects of care identified. Patients should be transported to a certified stroke center. At these hospitals, there's a stroke team, which helps to expedite the process of evaluating and treating a stroke patient. So how long do we assess the stroke patient? Well, we begin with a primary assessment, and this covers the ABC. You might want to look at Table 57-7 for the emergency management of the stroke patient. Be aware that these patients are at risk for airway compromise due to a decreased LOC. We want the oxygen saturation to be greater than 95%. What about circulation? Well, we want to establish IV access with normal saline. Once the ABCs are secure, we then begin the secondary assessment, which includes a comprehensive neuro assessment. To gauge patient outcomes and determine a baseline assessment, we'll use a standardized assessment tool. I've included here on this slide the websites for anyone interested. You can become certified in advanced stroke life support. There are several assessment tools used, but the NIH Stroke Scale is the gold standard for stroke assessment. The purpose of the NIHSS is to consistently assess patients and determine the effects of a stroke. It also provides a common language for exchange of information, and it is a predictor of short and long-term outcomes. You are required to complete the NIH Stroke Scale training for this course. Be aware you may also hear of a MEND exam, MEND, and a Cincinnati Pre-Hospital Stroke Scale. The NIH Stroke Scale is very thorough, but it is time-consuming. The MEND exam is called the Miami Emergency Neurological Deficit Exam, and it incorporates other stroke scales and the NIHSS stroke scale. It's quicker than the NIHSS, and it's more complete than some of the other scales. The NIHSS stroke scale is completed at least every 12 hours in a hospitalized patient, and the MEND is performed every 4 hours or with a change in level of consciousness or neurofunction. Now we're going to look at nursing history. If the patient is stable, the nurse is responsible for obtaining a thorough history from the patient, family, or caregiver. You want to include the following. Notice how the time of when the patient was last seen normal was, and this is important. You'll want to ask this rather than when did the symptoms start. This is because a lot of strokes can happen when the patient's sleeping, so really we don't know when the symptoms started if the patient was sleeping, right? We only know when the last time was that the patient seemed normal, and this will be important in a few minutes. Of course, we also want to get a history of similar symptoms. Maybe they've had TIAs in the past. What are their current medications? What are their risk factors? And is there a family history? Potential nursing diagnoses will center around a variety of areas. Of course, number one is the decreased intracranial adaptive capacity. And then we have to worry about the complications, risk for aspiration, impaired physical mobility, impaired verbal communication, unilateral or one-sided neglect. There may be problems with urinary elimination, or swallowing is a big one. We certainly don't want them to aspirate because they can't swallow. And they also have low self-esteem, some more than others. Health promotion is really critical. We want to do frequent blood pressure screenings, also screening for blood glucose, as well as medication adherence. And then there's those modifiable risk factors that we've talked about previously. Now we're going to look at the ABCs. So let's consider what's happening during an acute stroke. Just like the airway compromise that we discussed in acute intracranial problems, the stroke patient is at risk for compromised airway and breathing patterns. So we want to monitor lungs. We may need to insert an artificial airway and implement mechanical ventilation therapy. We certainly want to avoid hypoxia that can increase ICP. And we may want to administer oxygen to keep the oxygen saturations greater than 95%. Of course, prevent aspiration is important, suction if needed, and implement dysphagia screening. We may need to keep the patient NPO until a speech therapist can evaluate their swallowing ability. Our next priority is maintaining cerebral perfusion in a stroke patient. Nursing responsibilities include frequent neuroassessment using the NIHSS, the MEND exam, and a comprehensive neuroassessment. Remember, it's important to establish a baseline quickly and monitor for changes because this reflects cerebral perfusion. Remember, any change in level of consciousness must be addressed. Your goal is normohydration. Overhydration can increase cerebral edema. So we're going to monitor the INOs to prevent dehydration. Remember to assess for problems with pituitary involvement, such as SI-ADH or DI. These affect fluid volume status and cerebral edema. Also, remember to avoid IV solutions containing dextrose and water because they are hypotonic and may increase cerebral edema. You're going to implement all the nursing interventions for a patient with increased ICP if needed to maintain cerebral perfusion. Once we've assessed the patient and secured the ABCs and obtained the CAT scan, we want to know whether the patient has an ischemic stroke or hemorrhagic stroke. So now we can focus on survival. We have to maintain cerebral tissue perfusion. So how do we do that? Well, it depends on what kind of stroke it is. The drug therapy is decided depending on what kind of stroke the patient has. Ischemic strokes can be treated with a special fibrinolytic called recombinant tissue plasminogen activator, otherwise known as TPA. Other fibrinolytics cannot be substituted for TPA. The timing of TPA is critical. It must be given IV within 3 to 4.5 hours of the onset of clinical signs of an ischemic stroke. Patients must be screened carefully for this medication because it's very risky. This is not given if there's a chance of a hemorrhagic stroke occurring. Blood tests also need to be performed to rule out coagulation disorders. Also consider any recent GI bleeds, strokes, or head trauma within the last 3 months, or major surgery in the past 14 days. All of these must be ruled out in order to give this medication. If given, you'll want to insert all of the indwelling devices such as a catheter, NG tube, IVs, etc., prior to giving TPA, because this patient's going to be at major risk of bleeding after the TPA is started. During infusion of the drug, the patient should be a one-on-one with the nurse and very close monitoring of vital signs and neurostatus using the MEND exam and the NIHSS stroke scale because of the high risk of intracerebral hemorrhage. Blood pressure control is also extremely important. We want the blood pressure to be less than 185 over 110 to give this medication and maintained at 180 over 105 or less for at least 24 hours after TPA is given. TPA can also be given intra-arterially, and this can be given up to 6 hours after stroke onset. This is where the interventional radiologist, usually it's this kind of person, will insert a small catheter into an artery and guide the catheter to the area of the clot and then inject TPA right on the clot. The advantage of this is that there's less TPA to be given systemically, and there's more time allowance. 6 hours is quite a big difference. The reason this isn't performed all the time is because not all hospitals have interventional radiologists that are able to perform this procedure. For those patients with ischemic stroke who do not receive TPA, antihypertensive medications are only given if the blood pressure is markedly increased. You'll see on the slide, we'll only treat the blood pressure if the systolic is greater than 220 or the diastolic is greater than 120. Remember, this is because we're hoping to increase CPP around the area of the clot. But we must assess for any change in neurostatus because now our patient is at risk for a hemorrhagic stroke because of the high blood pressure. In hemorrhagic strokes, the main goal with drug therapy is blood pressure control because uncontrolled blood pressure can cause worsened bleeding. The goal is to maintain a systolic blood pressure less than 160. These patients are also at risk for seizures, so seizure prophylaxis may be implemented. Nimodipine is a calcium channel blocker given to some patients to prevent vasospasms who've had a hemorrhagic stroke from a subarachnoid hemorrhage. Vasospasms will further decrease blood flow and increase cerebral edema. Nursing implications for nimodipine are the same as for other calcium channel blockers. You'll need to monitor the pulse and the blood pressure and hold the medication for bradycardia or hypotension. Another tool that may be used in the collaborative care of the patient with stroke is surgical therapy. For the ischemic stroke, the clot may be able to be removed through a stent or a type of retriever called the Mercy retriever. Nursing implications include monitoring the suction site of the catheter and monitoring for increased ICP or signs of deteriorating neurostatus after the procedure. For the hemorrhagic stroke, evacuation of blood may be needed. If the patient has an aneurysm, clipping or coiling of the aneurysm will be performed, and then hemodilution-induced hypertension may be implemented using vasopressors such as phenylephrine or dopamine to increase the MAP and increase CPP. If there is bleeding inside the ventricles, an EVD or ventriculostomy may be placed. The nursing interventions for ventriculostomy and cranial surgery are discussed in the Acute Intracranial Problems lecture. Now that we've discussed prevention and the nursing responsibilities to improve cerebral perfusion, let's discuss preventing the complications from a stroke. The patient with a stroke is at risk for developing complications in every body system. For cardiovascular prevention, we'll focus on maintaining homeostasis. The patient's at risk for fluid imbalance and blood pressure variations. So we want to monitor vital signs frequently, including the MAP and the CVP. Monitor cardiac rhythms. Venous thromboembolism prophylaxis is also important because the patient may be weak or paralyzed. Range of motion exercises are important. SCDs, or low molecular weight heparin administration, may be needed. The weak or paralyzed patient is at risk for contractures and muscular atrophy. Range of motion exercises will help with these as well as other measures to optimize musculoskeletal function. These include a trochanter roll at the hip to prevent external rotation, hand cones, arm supports, posterior leg splints, and hand splints can also be used. The patient with a stroke is at high risk for skin breakdown due to immobility, also numbness or paralysis. Vigilant nursing care is required to prevent skin breakdown, so reposition the patient every 2 hours, but not more than 30 minutes on the weak or paralyzed side. Also promote nutrition, hydration, and prevent prolonged moisture on the skin. The patient's also at risk for constipation due to the same reasons. You may need stool softeners. Keep the patient hydrated, and if possible, promote as much physical activity as tolerated. Be sure to avoid vagal stimulation since this can increase ICP. A bowel training program may be needed if the patient loses the urge to have a BM. Be sure to assess the GI system regularly to assess for hypoactive bowel sounds or distension or rigidity. The stroke patient may experience poor bladder control or functional incontinence, in which the patient has problems with communicating the need to void, or they may have mobility problems. You want to avoid an indwelling catheter if possible. Assess the patient often for bladder distension if he or she is not voiding. A bladder retraining program may need to be implemented. Nutrition is a huge problem for stroke patients. It takes a lot of muscles and coordination to chew food and swallow properly. Your goal is to feed these patients within 72 hours of admission. The important thing to remember is that the patient is at high risk for aspiration. A dysphagia screen needs to be performed prior to beginning feedings. The RN or speech therapist can perform a dysphagia screen. You're looking for any coughing or choking, change in voice quality or lung sounds, or an increase in temperature after giving the patient small sips of water or ice chips. If this happens, keep the patient NPO until a speech therapist can evaluate the patient. Food may need to consist of soft, mechanical type consistency, so avoid thin liquids which are easier to aspirate, and encourage the patient to chew on the unaffected side of the mouth. Thorough oral hygiene is important after eating, since these patients are prone to pocketing food in the unaffected side because they can't feel or move that side of the mouth. Communication is very significant for the stroke patient. Depending on the area of the brain that's impacted, the patient may have forms of aphasia. Aphasia is the inability to communicate or impaired ability to communicate. Aphasia is also called dysphagia. The patient can have various forms of aphasia, either receptive, in which the patient cannot understand what is being said, or expressive, where the patient can understand but can produce language, or global aphasia, in which the patient has the total inability to communicate. Aphasia can also be described as non-fluent, in which speech is very difficult and it takes obvious effort to form the words, or fluent, in which the patient can easily form words but they have little meaning. Expressive aphasia can be extremely frustrating for patients because they can understand you, but they can't form the words, or the words come out inappropriately. The best thing you can do is to acknowledge to the patient that you understand the problems they're having and give them plenty of time to answer the question. Dysarthria is problems with mechanics of speech. It's the muscular involvement that is impaired. This is really frustrating for patients. Patients can also have a mixture of any types of aphasia and dysarthria. The patient is also at risk for sensory perceptual problems. They're at risk for high falls due to difficulty judging positions, distance, and rate of movement, so implement appropriate fall precautions. There's a problem called homonymous hemianopsia, which is blindness in the same half of each visual field, and it's common after a stroke. This will manifest itself as a persistent disregard of objects in part of the visual field. You'll see that the patient ignores all the objects, for example, on the left side of the food tray or bedside table, and this is because the patient can't see that side. You as a nurse will need to, at first, arrange all of the food or items inside the visual field. Later, you can work with the patient on consciously attending to the neglected side, so teach the patient to scan to that side. Sometimes the patients will have what's called neglect syndrome, in which they just totally neglect that side altogether. This places them at risk for injury to that side and potentially falls. Nursing interventions include close observation, raising the side rails, lowering the head of the bed, keeping objects out of the walking path, and anticipating potential safety hazards. A stroke is a sudden, extremely stressful event for the patient, the caregiver, family, and significant others. We want to use appropriate nursing interventions to educate the family and the patient on what has happened in the plan of care. Be aware that anxiety, fear, and depression may be present. Create a communication plan, especially for the patient with communication difficulties. A social services referral may be appropriate to get the patient help at home. Discharge planning begins on the first day of admission. These patients may be discharged from the hospital to home or to an intermediate or long-term care or rehabilitation facility. The most important factor to consider when planning discharge is the patient's level of independence with ADLs. How much assistance does this person need? Can they safely go home? Probably not. You must consider total care in discharge teaching. These patients are going to need several disciplines in their plan of care, including PT, OT, and speech therapy. Ongoing rehabilitation is essential for the patient to reach their maximum functioning ability, and most will reach this in the first year after a stroke. Rehabilitation requires a team approach, and it's important to remember that interventions initiated in the acute phase of care continue throughout rehab. It should be a seamless transition. During the rehabilitation period, musculoskeletal function is a priority. Initially, the focus is on tasks of eating, toileting, and walking. We need to determine what stage of muscle recovery there is and start the process from there. Just be aware that there are various methodologies that will guide the rehab part of the musculoskeletal system, and we will use physical therapy to guide the care of the patient here. Patients who have experienced a stroke may have atypical or inappropriate emotional responses. These include exaggerated mood swings, uncontrollable behaviors or emotions, especially in patients with left hemisphere stroke, and they manifest as right-sided hemiplegia. These behaviors can be difficult for the patient and the family. Nursing implications for this kind of behavior include distracting the patient, explaining emotional outbursts, establishing a calm environment, and avoid shaming or scolding. The patient, caregiver, and family are going to need help coping with the various losses associated with a stroke. These losses may be sensory, intellectual, communicative, functional, role behavior, emotional, or social. The patient and family will progress through the grief process. Depression, anxiety, and fear may all manifest itself in the form of weight loss, poor appetite, and sleep disturbances. The nurse can assist the patient and the family process through coping by facilitating communication, discussing lifestyle changes, and changing roles and responsibilities, being an active listener, helping to establish short and long-term planning with family and patient involvement. Have family conferences. For additional resources, you can go to websites for the National Stroke Association, the National Institute of Neurological Disorders and Stroke, the Association of Rehabilitation Nurses, the American Stroke Association, and the American Association of Neuroscience Nurses. And finally, remember that time lost is brain lost. This ends the last lecture on the neuro unit, which covers stroke.